Let's talk about troubleshooting of this Salem sump tube. So for instance, it should be on low intermittent suction most likely, and there's a couple of reasons why it would not be working correctly. If your patient has increased bloating and nauseousness, you should suspect that your tube is not sucking out like it's supposed to. So inspect the tube to see if it's patent. Sometimes maybe they have too much mucus, and they can take sips of ice chips, and that will help lubricate the tube and thin some secretions in the stomach so that it can suck out more efficiently. Other things to do is check your equipment. So we have bloating, nauseousness. That means this isn't working. Something's wrong with it. Is it connected here? Most likely there's not going to be any holes in your tubing. This tubing is really thick, so it's going to be a problem with this thing. Most likely it's this. So you can take this thing and you'll want to check it for cracks, okay, and you want to see if all of these things are down all the way. If any part of it is open, it's not going to create a suction. So you want to clamp it all down, make sure it's sealed good. Make sure this is sealed good. Make sure it's turned on where it's supposed to be. You know, so turn it on. So then just wait and see if it starts sucking out, okay? If all anything, you could unhook here, take a syringe and aspirate to see if anything's coming out. Generally, whatever you take out of a stomach, you put it back in. This is especially true for tube feedings. Now this tube is not usually used for feedings. We'd use an 11 tube, which is really thin tube that's used for a short to long-term feeding through an NG tube. Then maybe they'll get a PEG tube later. But let's say we have 11 tube in. We're going to check residuals. So when we check residuals, we're going to check residuals. We would clamp the tube. That part comes out too. We're going to pretend this is an 11 tube, like a feeding tube. You're going to check residuals, however much you get out. So let's say I got a whole 60 cc's. Okay, I always bring a couple of syringes with you when you're going to check residuals. So I got 60. Stuck there. Okay. All right, let's pretend I have another tube and I pulled out, let's say 30 more. So that's 90 cc's. Okay, and I didn't get anything else out. That's your residual, maybe right before you're going to go give another feeding. We want to refeed that because it's partially digested food and the body needs that. It doesn't want to start all over digesting food again, so we're going to give it back. So you would just refeed that real slow, about like that. It doesn't have to be terribly slow, but you're going to put it back in. You would put back in the other syringe too. Whatever you took out, put it back in. Okay, so that would be an okay amount of residual to go ahead and start your next feeding. Let's say if I'm going to give a bolus feeding, I might have like my Ensure here, my Boost or something, or whatever type of formula that this patient's going to get. You would just use a regular syringe like this. Put it in there. You would take your formula and you would just pour it in, and you're going to feed to gravity. That's a bolus feeding. So my residual was good that time. Okay, well then when do we have too much residual? We can have too much residual when the stomach is having delayed gastric emptying, and maybe they're not digesting as quickly as we like. And we'll know that when we have more than 250 cc's of residual for 2 assessments. That means, let's say at this assessment I do my residual and it's like 260. Okay, that's too much. That means I'm going to hold my feeding and I'm going to wait till it's time. I'm going to wait an hour and I can come recheck in an hour. In an hour I recheck and it's 250 again, or 260 again, or over 250. So now, okay, I'm going to hold the feeding until it's time for the next feeding. I'm going to check my residual again, and it should be down by then, but if it's not, then you would notify your physician that you've had too much residual and what they want you to do about it. Let's say a patient is having a lot of diarrhea. So if they have a lot of diarrhea with feedings, then that means that their formula is just super concentrated with a lot of calories. With a lot of calories, then the stomach wants to get rid of it really fast. And when that happens, it's called dumping syndrome. We'll talk about that later. But it makes the body flood water into the intestines to help dilute some of that high caloric food. In order to combat that, we'll dilute it ourselves. We'll add water to the formula. Adding water to the formula will help stop some of that diarrhea from happening. So we want to also replace some of that fluid they're losing. So if we add water, it will help stop some of that diarrhea from tube feedings.